Evening, everyone. My name is Amy Rylance. I'm the Assistant Director of Health Improvement at Prostate Cancer UK. And it's lovely to be back on a screen with the Rad Chat guys. I've done a couple of things with you in the past, but it's great to be able to once again reach out to the many people who've engaged with Rad Chat and talk about what we as a charity can offer beyond what I think most of you listening will know us for. So I think we have a very strong reputation in producing excellent health information for your patients, our fabulous specialist nurses. But actually, we also have a really rich offering for health professionals, and that's what I wanted to briefly touch on today. If you could just move me along to the next slide, please. So I just wanted to give you a little flavour, really, of the kind of things that we run here through some feedback from people who've participated in our courses. So every year we run a specialist conference. It started its life many years ago now as a CNS conference. And then we had more and more people who were not CNSs saying, can I come along to this? And we went, do you know what, let's just make it appropriate for the whole multidisciplinary team who are supporting men with prostate cancer. And it has absolutely gone from strength to strength. And it's a really practical program. It's really focused on increasing your understanding so that you are better equipped to be able to support the patients that you are working with. And we've got some lovely feedback on here from some of our participants. But we also run courses where the research base is shifting, where the practice is shifting. So, for example, we ran a big conference around active surveillance and how we can better risk stratify men who are undergoing active surveillance. We've recently run a conference looking at how the evidence base around the PSA test has shifted. And if you could give me the next slide, please. If you're looking at that thinking, oh, I'm gutted I missed any of that, our online learning platform is for you. So there's a QR code here that you can scan so that you can see the link for that and save it on your phone. But our online learning platform is wonderful. It has the kind of essential CPD type knowledge, the kind of core skills in prostate cancer, but it also has an amazing library of past recordings, webinars, things that you can explore by topic or by particular issue, and also a lot of resources in the research space where we ourselves have been publishing research to move forward the evidence base around prostate cancer. All of that is within our online learning platform. It's designed to be really easy to navigate for a busy professional. And finally, if I could just have the next slide, if you're thinking, oh, I didn't know about any of this, it's quite interesting stuff, but I can never stay on top of all of this. The easiest thing to do is to scan this QR code, which takes you through to an online form. If you fill in your information on there, it means that we add you to our clinical update mailing list. It does not mean that we will bomb you with communications. Don't panic. We send you roughly one email a month. And it just means that we will let you know when there are new courses available on our online learning platform, when the guidelines shift, when best practice is changing, new patient support information, all of those kind of things. So really easy way to stay on top of what's happening. And I'm going to wrap up there and pass back to you, Kath.
Hi, sorry, it's Jo. Sorry. So now, without further ado, we're going to play a video, I believe, that just talks through some of the amazing things that are available at Prostate Cancer UK.
Hi, I'm Kavita Tailor, and I'm the Senior Healthcare Improvement Officer at Prostate Cancer UK. And I'm excited to introduce you to our free 18-month flagship Clinical Champions programme.
This unique leadership programme is designed for primary and secondary healthcare professionals who are dedicated to enhancing support and care for men affected by prostate cancer. In partnership with Living Potential, a renowned leadership development organisation, we offer innovative content covering change leadership, leadership communication, the practice of articulating a vision for change and conveying emotions effectively, improvement science, and support to implement an improvement project. Take Sian, a therapeutic radiographer from Bath. She joined our program with the ambition of developing a prehabilitation service for men undergoing radiotherapy for prostate cancer. With our support, Sian successfully launched a pilot prehab service in her department. She describes our program as the most valuable professional development she has undertaken, which has significantly impacted her outlook on leadership. Throughout the program, Sian discovered her unconscious drive for perfection and learned to be less critical of herself. This led to reduced stress at work and a healthier work-life balance, allowing her to focus less on work-related pressures. After 4 successful years, we are now recruiting for Cohort 5. Don't miss out this opportunity to join our free program. Scan the QR code to find out more and to register your interest, or email us at improvement@prostatecanceruk.org to chat with one of our team members. Join us in making a difference in prostate cancer care.
Amazing work. Amy, can I just ask you a question? In terms of kind of impact, what's been the biggest thing that you've kind of heard people talking about who've used the resources to actually educate themselves and then obviously maybe change or implement into practice?
Yeah, that's a really great question. I think there's 2 quite distinct areas to our education. So the online learning platform focuses more on kind of practical skills, the what of healthcare, what should you be doing? Whereas what Kavita has just been talking about, our improvement programs are much more in the space of how. How do you make change? And I think actually, interestingly, I think that's where we have the biggest impact, because if we can support somebody to change a system, to change the way that care is delivered across a trust, that starts to change the experience of thousands of men. And so really within our clinical champions program and the broader improvement programs, that's where we start to see really significant life-changing impacts for men.
The improvements program is really good. I went through it as well. That's where we met. And getting the chance to network with so many different professionals across the vast urology pathway was really nice. And then, as you said, seeing it work into practice. Yeah, obviously very biased talking about it, but yeah, I really enjoyed it. And it was just nice to meet more people, because it was just after the pandemic as well, so bringing people back together. So yeah.
I think one of the bits of feedback that we have is it's quite unique as a leadership program, that generally when you step into that space, you step away from your clinical expertise. And often, that journey into leadership in the NHS is often about stepping away from your patients, whereas our leadership programs are not about that at all. They are about immersing yourself in the multidisciplinary team and learning how to be a leader within that team to improve care for your patients. And I think that is a fundamental difference to other leadership programs and a real strength of the program.
With the resources, Amy, how do they transfer from all the different areas of kind of healthcare, so primary and secondary care as well?
Yes, so when you register to join our clinical mailing list, we actually ask you which sector you work in, because we do recognise that the needs, the information needs are very different. The guidance changes have different impact. So we do tailor our communications. So we have a quite distinct mailing to primary care compared to secondary care, to try and make sure that we know everyone's really time poor, and we don't want to be sending you useless information. And so we try and make sure what we're sending you is tailored to what you're actually going to find useful.
Amazing. Right. Well, thank you so much, Amy. That was really insightful. And I'm sure that anyone who is inspired by the conversation this evening will go on and have a look at those things. So I'm really pleased to introduce now Dr. Clive Peedell. Clive, would you like to introduce yourself, please?
Yeah, no, thanks so much for inviting me. We had a chat recently, didn't we? Did one of these, and it was great fun. So it's lovely to be back. I'm a consultant clinical oncologist from James Cook University Hospital in Middlesbrough. I manage prostate cancer and lung cancer, and I've got a major interest in stereotactic radiotherapy. I'm a member of the steering committee of the UK SABRE Consortium, which has been really instrumental in getting every UK centre now to offer, stereotactic radiotherapy. And that's one of the great things about it, is it's accessible, it's available everywhere, and it's becoming a standard of care in the management of early stage prostate cancer. So we'll definitely be talking a bit about that in a second.
So, Clive, for anyone who's maybe brand new to radiotherapy, can you talk us through a little bit about why it's used in the management of prostate cancer, please?
Yeah, that's really important. We've got a wide-ranging audience there. So just a bit of background, really. I mean, radiotherapy is just essentially using ionizing radiation to treat malignant disease, treat cancer, generally sort of X-ray type treatments. And in prostate cancer, it's used to treat all stages of disease, actually. So you can give what we call radical radiotherapy, which is very high dose focused radiotherapy to treat the early stages and locally advanced disease. And you can use more palliative schedules of radiotherapy to treat in the palliative metastatic setting. So you can treat, bone pain, for example, so bone metastases. You can treat obstructive symptoms from the prostate, or if patients are bleeding from the prostate, you can use palliative radiotherapy to help stop the bleeding. So it's used in all stages of prostate cancer.
Great question, Clive, but what's changed in the last 10 years?
Yeah, that's a fantastic question. I was just saying earlier that I just love my job. It's just so exciting at the moment what's going on in the field. Both, also systemic therapy as well. My medical oncology colleagues are doing amazing things in prostate cancer as well, and cancer across the board. But in terms of radiotherapy specifically, big changes over the last 10 years. Now, if you'd have come to my clinic with a localized prostate cancer 10 years ago, I'd be consenting you to have 37 fractions, or 7.5 weeks of radiotherapy every day, Monday to Friday, about sort of 10-minute session, 5 days a week for 7.5 weeks. And I just remember seeing patients sort of roll their eyes thinking, crikey, and they're looking at each other and thinking, how am I going to sort transport out? And is my son available, and what's my sister doing? Can they get a car? Have you got hospital transport? And it was a blooming nightmare. But we've had some amazing trials published, actually led by the Brits, actually. A huge trial called the CHIP trial that was published in 2016, led by sort of David Durnley from the Royal Marsden, and that showed that 20 fractions, so 20 treatments over 4 weeks, was just as effective as given 7.5 weeks. So you give a slightly bigger dose per fraction, and because the radiotherapy techniques had improved, you could do that safely, and there was no difference in side effects. So it's a no-brainer. Let's go for 20 treatments instead of 37. And what had been happening in North America and Europe at the same time was there were lots of studies going on with a technique called stereotactic radiotherapy. And basically, that's just a more accurate form of delivering radiotherapy, given in even smaller numbers of fractions with a even bigger dose per fraction. And it can be just as safe because you're using smaller margins around the tumour, therefore less normal tissue getting treated. So this has all been facilitated by two major advancements in radiation technology. One is what's called intensity modulated radiotherapy. That just allows you to sort of treat concave volumes. So you can treat around the rectum more accurately. So you give less dose to the rectum, and you can shape the beam around the sort of the bladder and those sorts of areas to minimize the sort of urinary toxicity as well, because then the main toxicity is bowel and bladder. So we can be much more accurate in that regard. And the other key thing was the advent of image guided radiation. So on linear accelerators, so the modern treatment machines, you've actually got CT scanners bolted onto the side, and they take a CT scan, and you can actually see if the patient's setting up in exactly the same position. So we compare the scan on the treatment couch to the scan the patients had in the planning scan. If they're slightly out of position, our wonderful radiographers can use the technology to shift the couch to literally move the patient a few millimeters in the right direction, so you can hit the target. So we're much more accurate in terms of our treatment delivery. And that allowed us to treat in even fewer fractions. And so stereotactic radiotherapy, which sort of started off in sort of lung cancer, and that's why I've got a major interest here, because that's one of my other specialties, got into the field of prostate cancer. And some fantastic studies called the PACE trials, based from the Royal Marsden, but, patients were recruited from all over the country. We recruited loads in Middlesbrough, and they've shown fantastically that 5 fractions is just as good as 20 fractions. So, I mean, you can imagine how patients feel now in the clinic. They come and see me and I say, look, I can, treat you with 5 fractions now instead of 20, which is, fantastic. So it's good for radiation departments. It's good for patients because they don't have to come as often. And we've got a lot more capacity in the department. So, it's been an absolute revolution in the field. And I think the surgeon's feeling a bit threatened now, because if you just got a chance of having 5 treatments, then, why have surgery when you've got a big trial like the tech trial that showed no difference in survival between radiation, active surveillance, and prostate cancer in the sort of low risk group and sort of lower intermediate risk groups. For those patients, there's a really interesting debate to be had, and I think another conversation for another rad chat, I think.
Absolutely. Well, you've signed yourself up already there, Clive. Thank you for that.
Yeah, we'll have to have a debate with the surgeon, and it's not fair without a surgeon here to defend themselves. There might be one on the call, so maybe they can jump in, but we'll maybe come back to that.
Yeah, absolutely. So Clive, in terms of from a patient's perspective, because I'm just thinking people in the audience may have that role in terms of supporting their patients, how can they support them in kind of having these discussions with their oncologist versus their surgeon, but also thinking about, what can they expect from their interaction going through a radiotherapy pathway?
Yeah, that's a great question. I think in the UK, to be fair, we've got a wonderful thing called the MDT, the multidisciplinary meeting. So all the cases are discussed in the multidisciplinary meeting. Because the thing with the diagnostic pathway is done by the urologist. So if you're in the United States, where it's a very money-driven system, you get paid for what you do, the urologist might keep the patients and not refer them on for a radiotherapy chat. It's a completely different world over there. Whereas in this country, there'll be a fair discussion at the MDT. And I think the really important thing to say is actually for low risk patients, active surveillance is probably the management of choice, actually. So that's really important to, although I'm, talking favorably about radiotherapy, active surveillance is a very important treatment or management option for men with definitely low risk and some intermediate risk patients as well. Again, that PROTECT trial, the 15-year data was just published in the New England Journal, the most important clinical journal that we have in medicine. And that showed no difference at 15 years in overall survival for that group of patients. So, it's an individual choice. Active surveillance isn't without its problems. You've got to come back for sort of MRI scans, and you've got to have potentially repeat biopsies, and that's not the most pleasant procedure in the world. Some men would never want to go through a prostate biopsy again. Others tolerate it fine. But these are all really important things to consider. But yeah, I think it's very important now to have the option to speak to a radiation oncologist if you've got a localized prostate cancer, because radiotherapy is a very good treatment option. We also treat the higher risk disease as well. There's ongoing trials, again, with using stereotactic radiotherapy in higher risk disease as well now. So some centres are offering entry into what's called the PACE Nodes trial. We've opened that where we are as well. But really important to have that opportunity to speak to a radiation oncologist, because again, the PACE-A trial compared radiotherapy, so stereotactic radiotherapy, to surgery, and there was a much higher incidence of urinary toxicity in the surgical arm and sexual dysfunction, and there was a higher incidence of bowel toxicity in the radiotherapy arm. But I would strongly argue that bowel toxicity is very minimal, it's manageable, and it's not as bad as a 50% risk of wearing a pad at 2 years. That's what surgery will give you, a 50% risk of wearing a pad at least once a day at 2 years compared to 5%, and a 30% risk of erectile dysfunction versus an 18% risk. So, I mean, patients deserve to know. The other issue with I said I wouldn't debate the surgeons, but I'm here now. The other issue with surgery, and the really important question for patients to ask if they go for surgery, and they should ask, how many procedures have you done? Because there's a really interesting and significant learning curve to robotic surgery, and they have a very high rate of positive resection margins, which means that you might end up with radiotherapy afterwards as well, when you could have just had one modality of treatment. So ask your surgeon how experienced they are, and if they've done less than sort of 20, 30 operations, unfortunately, I wouldn't want to have surgery under those circumstances. That's a key question.
As all of this technology advances this sort of treatment, Clive, what do you envisage in the future for how patients experience side effects?
Yeah, so one of the really interesting thing about the side effects is that they are decreasing over time in the clinical trials. If you look at the CHIP trial, the control arm, 60 Gray and 20 fractions. The control arm in the PACE-B trial was also 60 Gray and 20 fractions. And actually, there was lower side effects when you compare those two studies. So if you look back, I mean, you're looking at separate studies, but actually, they're huge studies, lots of patients in those studies. So we were seeing, much less grade 1 and 2 toxicity in the latest trials. And that's a trend across all radiotherapy trials. We're seeing side effects come right down. And most of them are manageable. In terms of grade 3 toxicity, which is the sort of toxicity where you might end up in hospital with a significant complication, we're seeing less than 1% now in stereotactic radiotherapy getting sort of like a grade 3 toxicity. So it's it is amazing, and it's so impressive with 5 fractions. We're trying to go harder now and faster. A trial, the Hermes trial, being done at the Royal Marsden, that they're fortunate to have an MRI LINAC, so that we have CT guidance, but there are now MRI linear accelerators, and they're doing a 2 fraction regimen, and we should get the results from those sorts of studies in the next few years. So that's going to be really interesting. I'm not sure how practical that is up and down the country, whether anybody's going to be particularly bothered having 5 or 2 fractions. I mean, I treat lung cancer, and there's different fractionation schedules. My common schedules are 5 fractions or 3 fractions, but I also do radiosurgery. I do single fraction to lung. And patients are not that bothered if they come for 5 or 3. They do actually like coming for a single. That's great. But I don't think that's going to work in prostate cancer. There is a one-shot trial, it's called. They've done with a single fraction of stereotactic radiotherapy to the prostate. But I think it's going to have the same sort of issues that the brachytherapy trials have had, that if you give a single treatment, it doesn't seem to be enough in prostate cancer. You need to give at least 2 fractions of radiotherapy to have the maximum effect. So lots of amazing studies going on. But the studies that are trying to give those really high doses in 2 fractions, you end up potentially having to have a catheter and, having to have a spacer, which is, injecting some sort of liquid substance between the rectum and the prostate to get a distance between them to minimize side effects. And that suddenly takes an invasive treatment to a non-invasive treatment to an invasive treatment. So I'm not sure how many men will want to go along that approach. I mean, we've certainly offered it in Middlesbrough and had that service. So it's a fascinating area, and it's really exciting for the future.
And obviously, there are benefits to coming every day to see your radiotherapy team, aren't there?
I mean, it's I think that's a really important point. There's so many chaps I speak to who actually enjoyed their radiotherapy because they had a social bit of banter, and they just one of the things I get about the radiographers, and I'm sure it's in most centres and hopefully every centre, is that the patients really appreciate their time with the radiographers. I've never had so many sort of, can you say thanks back, to the radiographers, and they really make the whole process manageable, comfortable, and quite fun sometimes, because the side effects aren't too bad. Don't get me wrong, there's the occasional patient, and I'll say this in clinic, you've got about a 20% chance of saying, did you turn the machine on? I had one of those today. I rang him up and said, how'd you get on? They said, I didn't have any side effects at all. Did you turn the machine on? And then most people will feel tired, a bit washed out, a bit of loose bowel. I normally say to them, when you go to the restaurant, the first thing you do is just check where the toilet is, just in case you have a bit of urgency or frequency. And then I'll probably get about 5% that'll have a bit of a rocky time, and then it'll all settle down. And maybe about 1% that say that they'll say, I'll say to them that you'll say, Dr. Peedell, I bloody hate you. You ruined my life, you know, because but it's rare. So you know, it's fantastic, and I've seen that. I've been a consultant 20 years, so it is definitely, you know, improving dramatically, and that whole experience with the radiographers is really, really important. So yeah, well, they may miss that a bit if they only come 5 times, but you're there, instead of a 10-minute appointment, you get there for 20 minutes, so you get double the time with them. So there you go, that's how I'd sell it.
Thank you. So the last question, Clive, is around kind of future advancements. So you mentioned a little bit kind of about the adaptive radiotherapy using the MR-Linac, but is there anything else that you think, you know, might further advance cancer treatment in this field, and anything that potentially within radiotherapy that people listening might never have heard about or even considered might be a future advancement in this area?
Yeah, and that's again another great question. You know, if another type of thing came along where you didn't ever need radiotherapy, you know, magic pill solve the problem, then I'd happy to be unemployed, you know, or manufacturing those pills. But yeah, that's obviously some time away. I mean, interestingly, if you look at intermediate risk disease, which was what the PACE-B trial looked at, and you don't get hormones with that. You don't need hormones with intermediate risk disease for the PACE-B trial. And that showed at 5 years, the PSA control was 96%. So you can't really get much better than that anyway. Obviously, there's still a few patients relapsing. You know, biologically, their disease is behaving in a way that's either radio resistant or the cancer had already spread, you know, biologically. So you're looking at sort of systemic therapies that are going to make the rest of the difference. But like I say, hormones don't add anything in that situation. So it would have to be something different. In terms of technology, we talked about spacers. You know, they're really interesting in terms of they do reduce rectal toxicity and urinary toxicity, but, you know, we're pretty low level anyway. So is it worth having the invasive technique? You know, I go in and out of being pro and con spacers. I think it's for certain patients, in selected patients, I think it can be very useful. And I think if you're going really, really high dose, trying to get down to 2 fractions, you probably do need a spacer. And you may well need a spacer if you're dose escalating to higher risk disease. So if you've got more locally advanced disease, you probably need to give a higher dose of radiation. And because it's a bigger volume disease, you're more likely to irradiate more tissues around. Therefore, you want that spacer, you want that distance between the rectum and the prostate. Because no matter how accurate your radiotherapy, if your prostate is abutting the rectum, you know, they're touching each other. So it doesn't matter, you know, how accurate your radiotherapy is, that anterior wall, that front wall of the rectum is going to get irradiated. So, you know, if you've got a spacer to push it out of the way, that can help. So there's some of the technologies. Obviously, there's the MRI. I mean, really interestingly, obviously protons, that's a big issue again in the United States. A recent study has shown, you know, they're no better than IMRT, you know, the modern techniques. So, you know, £100 million sort of proton center, you know, versus an 8 million MRI Linac versus a 2 million normal CT based Linac. You know, I mean, it just doesn't make economic sense. And I'm really proud of the UK sort of proton you know, group. They made the right decision. They decided to have, you know, 2 proton centres nationally, one in the north in Manchester and one in London, which was the ideal way of going about it, because it's mainly a sort of paediatric benefit and for sort of specialised tumours. And we've really nailed the sort of use of protons in this country, whereas America, you know, there's proton facilities shutting down all over the place because they're just not economically viable. So that's one technology that I don't think is going to add much, especially in common cancers, common adult cancers. So that's the sort of long and short of it. I mean, eventually there'll be sort of molecular treatments that will overtake radiotherapy one day. I've sort of philosophized about it, and I think, you know, eventually there'll be something that will, you know, eventually conquer cancer. But, you know, we're a little way away. I mean, immunotherapy is really exciting, but again, still a long way to go.
Brilliant. Oh, well, thank you so much. I don't think we've got any questions in the chat. I think you've escaped. You've just had to have Mum and an eye.
Did the surgeon not turn up?
Maybe not. Or he heard you and left.
Yeah, he's fled.
I think it was the surgeon and the proton beam therapy team. They've all gone.
Yeah, he's gone to get his P45. He's gone.
Well, thank you so much, Clive. It's very much appreciated, and I know you're going to stay with us just in case there aren't any questions. So if you do have any questions for the amazing Dr. Clive Peedell, then please do drop them in the chat. So I'm absolutely delighted to now introduce my friend and colleague from Sheffield Hallam University, Kath Holborn. Thanks, Kath.
Thanks, Jo. Thank you to RadChat and Prostate Cancer UK for inviting me to speak this evening. So just a little bit of background on me before I get started. I'm a senior lecturer in radiotherapy and oncology at Sheffield Hallam with Jo. And I'm also the training and education lead at our Advanced Wellbeing Research Centre, where we mainly focus on research and innovations that are focused on improving lives through innovations that help people move more and be more physically active. I'm also a therapeutic radiographer by background as well, so I importantly get that in as well. Next slide, please. Off the back of Clive's talk and based on my teaching areas, I guess my areas of expertise and also personal interest and passion, I'm going to sort of take you through a series of key messages that I think are really important in terms of the supportive prostate cancer care side of things. So Clive's touched on this already, but my first key message, so all the key messages on each slide are in the italics, and then I'll sort of the quotation marks, sorry, and then I'll just expand a little bit on some of them. So Clive's touched on this already. Radical radiotherapy may now be used for all stages of prostate cancer. So I think that's a really key learning point and has implications for supportive care that we provide during the radiotherapy pathway. So obviously we might be treating patients with localized disease, low risk, intermediate, high risk, locally advanced, but also results of the Stampede trial have now shown that there is still a benefit to pelvic radiotherapy even for patients with low burden metastatic disease as well, alongside those other systemic treatments that are so important. And so my first key message in terms of supportive cancer care is, treatments can look quite similar now, can't they, on the treatment unit in terms of the VMAT that we use and the way that the machine sort of moves around the patient compared to when I worked clinically and we had different beam arrangements and things. So I think it's really important that given that spectrum of patients that are coming through for radiotherapy and potentially radical pelvic radiotherapy, it's really important that in terms of the care we provide, we recognise the differences in each patient's treatment plan and be mindful of their individual journey and experience. So considering things like, as Clive alluded to, patients with localised low to intermediate risk disease may not be on hormone therapy, so androgen deprivation therapy, but certainly those with higher risk, locally advanced disease, they will be on hormone therapy as well during the course of the radiotherapy. And also we need to think about, depending on the risk, are they on a short course of maybe 6 months? Or are they due to have what might be a minimum of 2 to 3 years continuation of that hormone therapy after the radiotherapy? And potentially for some, they may stay on it permanently, but lifelong. And as also Clive alluded to, what's the treatment volume? Obviously, the higher the risk, the more a larger volume we're encompassing. So we're including the seminal vesicles, encroaching more on that anterior rectal wall. We might also be including the pelvic lymph nodes, where small bowel toxicity is then also a concern as well. And some patients, again, nicely segueing from what Clive was talking about, some patients might have elected for surgery prior as their first main primary treatment, but then in terms of outcomes following surgery, they then need some form of adjuvant or early salvage radiotherapy as well. So it's really important to think about the journey they've been on, what other treatments they're having, and often it's the hormone therapy, for example, that really is having the biggest impact on quality of life as opposed to the radiotherapy. So I run a prostate cancer support group as well within my local area, and the men really do find this is the most difficult aspect. So in the short term, obviously, with fatigue, but obviously that would be an ongoing side effect as well. In the longer term, that can be really quite significant and life impacting, the fatigue for some men, particularly if they're on other treatments. So if they're having a multimodal treatment where they may be on other systemic treatments alongside that baseline hormone therapy like chemotherapy as well, and of course if they've had the radiotherapy also. Hot flush is also is quite a sort of immediate side effect from the hormone therapy. And then longer term we have issues to do with, well, short and longer term we have issues to do with the cognitive issues is a really common issue that men speak about in my support group. Frustration, feelings of anger, not being able to concentrate as well as they might have been able to previously. And in the longer term, those that are on these longer term courses of hormone therapy, problems with weight gain, particularly around the tummy, and this decline in muscle mass and strength, and a decline in bone strength, and feeling generally weaker as well. So I'll come back to perhaps some of those points in a moment, but I suppose a key message alongside this main one on the slide is that radiotherapy does, for some men, many men, particularly for the higher risk and locally advanced, it does come with the hormone therapy. And a lot of the men in my, we did some focus groups with some of the men in our support group, and we're asking about their radiotherapy experience. And as Clive has alluded to, they actually found it was quite an easy experience, relatively speaking. And the one thing they said in terms of what could we do to improve your radiotherapy experience was to get rid of the hormone therapy that needs to go alongside it. And potentially with Sabre, you know, like with the PACE trial that has shown that for intermediate risk, that's maybe not needed, that short-term course. There's perhaps some promising results on the horizon in that regard, at least for some men. Oh, next slide, please. Sorry, I was trying to move that on myself. My next key point is that despite technological advances that are definitely keeping the toxicity levels low at those lower grades that we hope to see, rather than the much higher grades where we would certainly not want to see men being hospitalised due to severe toxicities. So they are absolutely keeping side effects low, and some of the research with Sabre is indeed showing that there might even be an advantage in reductions in certain toxicities compared with perhaps the more conventional regimes. There can still be a notable impact on quality of life following radiotherapy for many men. And I've just put in the RTOG scoring, which is not a patient-reported outcome measure, it's more of a clinician-reported one. But if we look at the RTOG scoring for late toxicity, that's often a scale used in these trials. I've just included the grades 1 to 3 there, but so for bladder and small small intestine and large intestine and rectum, you can see that if you look at some of the common terms, it's patients living with a change in bowel and urinary habit, increased level of frequency in terms of how often they maybe need to go from a urinary perspective, but also bowel movements. At grade 1 there, you can see 5 times a day would be classed at that grade 1 level, including potential slight rectal discharge, mucus, or potential bleeding, albeit mild. And likewise for bladder, things like intermittent, again, not necessarily severe, but macroscopic hematuria, which might be a worrying symptom for some men. And again, with moderate frequency, grade 2 GI, sort of moderate diarrhea, bowel movements, colic, wind, flatulence is also these sort of problems we see as a late effect. So they are mild in that they're not life-threatening or severely life-limiting from a quality of life perspective. But imagine having those perhaps for a long period of your life or permanently, and they can certainly be side effects that without support can certainly have an impact on someone's quality of life and perhaps their social activities, and limiting those in terms of what they enjoy. And I also thought it was worth mentioning that, you know, erectile dysfunction is still a very common late effect of radiotherapy. So it is a late effect of radiotherapy that men need to be prepared for, but also obviously the ADT, when that's used combined with radiotherapy, that more immediately causes erectile dysfunction due to the loss of libido. So just being aware that, you know, it is, I've put that in because it is a common unmet need in terms of sexual support following treatment for men with prostate cancer, for both surgery and radiotherapy, and for men that are on long-term hormone therapy. And yeah, while it is a late effect, it is also already happening for many men in terms of the fact that they're having the hormone therapy at the same time during radiotherapy. Next slide, please. So just some key messages then. So what I've tried to set the scene there with is that obviously supported prostate cancer care is really important to enable this as much as possible a really good quality of life moving forwards, either living with and beyond treatment, or whilst they're still having continued treatment, for example, with the hormone therapies for higher risk or metastatic disease. So my next key point is that supported self-management is vital across the cancer pathway, and that should start from the point of diagnosis. And you can, I've put in a more detailed sort of description there as to what we mean by supported self-management. So it incorporates elements of rehabilitation and survivorship care. It's about adopting a personalised approach, seeking to understand what the individual needs and concerns are of that person and responding accordingly to those. And it's also about, so as you can see there, it's about helping, enabling and empowering the person to manage their own health and well-being, because a lot of these side effects beyond treatment, they don't need specialist intervention, but they can be impactful on quality of life if people don't know how to live in a way and engage in certain behaviours that are going to help manage those side effects and gain that quality of life that we're looking for. So there's key elements to supported self-management. There's obviously information provision and guidance is important in terms of building people's capacity, their knowledge and skills to know how to look after themselves and how they go about doing that, what they need to do, but also how. But also we know that some people are more activated off the back of information provision than others. And so for some people, it's really important that we combine that with sort of a health coaching and motivational interviewing style of approach that helps to build confidence in their capability, harnesses motivation, and allows someone to see where the opportunities are and the support network around them to enable them to engage in these things we would like them to live a healthy life with and beyond their cancer and its treatment. And psychological support, and also from including peer support, is known to be a really important element in terms of building that confidence as well. Next slide, please. So one of the main key messages in terms of supported self-management and an activity that is absolutely has to be better promoted, and obviously I'm doing my job here from an AWRC point of view in terms of the research centre where I work, where we do a lot of research in this area. This is my next key message. Physical activity, including pelvic floor exercises for prostate cancer patients, should be a core component that is fully integrated into the cancer pathway and personalised care plans for men with prostate cancer. So we know, for example, that physical activity can help to reduce the recurrence of cancer. It's good for general physical health and recovery after what we see as deconditioning during treatment. Obviously, pelvic floor exercises can be helpful in terms of that strengthening of the pelvic floor muscle that controls urinary continence, but also sexual function and bowel function. And it's really, really important in terms of particularly the strength-based exercises. It's so important, particularly for men that are on the long-term hormone therapy, where they are at risk of decline in muscle and bone strength and health, the physical activity is so important for those men in particular in maintaining muscle and bone strength, and also decreasing their risk of cardiovascular disease related complications as well, that the hormone therapy can place them at an increased risk of. So I've just sort of highlighted some key points there on this slide. The middle one is showing you the evidence base for an exercise prescription by the ACSM there, where there's a strong evidence base for that particular exercise prescription for cancer-related fatigue. So I've put that in because it is such a common side effect. PCUK obviously and others provide information on pelvic floor muscle exercises, why to do them, but also how. And there's the Squeezy app as well that's really a great resource. And then if you aren't familiar with the guidance on physical activity and what that should encompass, it should be, the World Health Organization talks about 150 minutes a week of moderate intensity exercise. So something that gets you out of breath for you. So that doesn't, it's not about a particular type of exercise, it's whatever gets that person a little bit out of breath and difficult. You know, they can still hold a conversation, but they've got their heart pumping a little bit more. So whatever that is for them. And also 2 days a week, there should be some exercise that involves moving their muscles that can help strengthen their muscles, bones and joints. So it might be involving some weights, but it could also involve things like just where they're carrying a bag to and from the shops. It could be using resistance bands, Pilates exercises like that, where they're using their body weight in certain exercises that they're undertaking. So I'll not labour on that point too much and go into loads of detail. Maybe that's another webinar, like Clive said. So next slide, please. And then finally, I was just thinking about, you know, I said at the start, what does supportive prostate cancer care look like, or supported self-management across the pathway, starting from the point of diagnosis and referral for radiotherapy? So it starts with good preparation for treatment. So that of course means things like preparation for bladder filling and rectal preparation that we know is important in terms of accuracy, but also achieving those great plans that we need to achieve where we're avoiding those organs at risk. There's obviously a mounting evidence base now around prehabilitation as part of that pre-treatment preparation process. So this is a particular intervention that is using physical activity, nutritional advice and psychological support to boost people's physical condition and psychological readiness prior to treatment in a general way. But also we can include targeted advice as part of that in terms of how people might manage symptoms specifically for prostate radiotherapy. So starting conversations early about pelvic floor exercises, keeping hydrated, avoiding bladder irritants, for example, which would then be continued and reinforced during treatment once they started treatment, combined with effective monitoring and early intervention when symptoms arise. It's so important that patients get a good experience because that can positively impact on their recovery as well in the longer term. We would then have, ideally, so this is the ideal, some form of early rehabilitation after treatment that again revisits those three core elements of physical activity, nutrition and psychological support to rebuild physical condition and psychological resilience that's inevitably dropped during treatment. But again, in a targeted way, this is when it could include a focus on specific side effects like early erectile dysfunction and penile rehabilitation. We also need to get much better, I think, this is just a personal opinion, radiographers can play a really good role here in terms of preparing patients to live healthily with and beyond and preparing them for how to cope with some of these late effects. So good quality end of treatment information and support that gives people the capability and the confidence to do that management of their own health and well-being. So for example, advice on eating well, being physically active, additional support around the sexual dysfunction side of things, like how to maintain intimacy, and so on. Another webinar there in itself, and I know you've had other speakers on that in the past. Toilet advice and advice on planning, prioritising, pacing, etc. for the management of fatigue. So these are all things that it's not the remit of a specialist. Anyone could be engaging in this and giving this information, and particularly anybody can signpost. So I think that's the most vital element of supported self-management, in my opinion. And people need to know, you know, when they sign that consent form and they're told about the potential late effects, they need to then know how to monitor for those in the longer term and where to get support if they are the people for whom they become particularly bothersome, because there are some really good late effects services out there now. And all of this is underpinned by a supportive conversation tailored to individual that seeks to understand individual concerns and needs and signposts accordingly. And then finally, just to round off, my final slide, sorry, is just if you want to move on. So I just wanted to highlight to everyone, if you didn't know, this really great document already. So particularly in terms of managing late effects, both particularly for healthcare professionals, a really good document to refer to, but also signposted here is PRADA's best practice pathway that covers all of the late effects and includes evidence base underpinning the management of them, or if that's not available, there's an expert consensus that's developed this. And I just want to end with, you know, everybody should play a role in the provision of supportive care. It shouldn't be the realm of specialists or people in advanced roles. Everyone has a role to play, and the most important thing you can do is to notice, inquire, listen, acknowledge and understand, and that is what will give that gateway of support that patients need and ensure that, you know, some of these unmet needs are better addressed. Thank you.
Amazing, Kath, and so much covered in such a short
Sorry,
space of
it's
time.
a large topic.
It's absolutely brilliant, and it's almost like a key gateway to come and see what else I have in store. So, Kath, I know you do some work with Prostate Cancer UK. What is there potentially that you're working on with them at the moment that for anyone who maybe wants more information about this can access?
So, I mean, it links to Clive's talk as well, actually, and I think I probably will be working with Prostate Cancer UK on some of the supportive prostate cancer care side of things, but I have been working with them to produce I suppose modules or courses for their online learning platform where people can learn about the management of prostate cancer, for example, at the different stages. So I know that one is due to be released on the management of locally advanced prostate cancer, where quite a lot of recent advances have taken place that Clive's already alluded to. And also I've written one, I think, that will be going live soon in relation to the diagnosis of prostate cancer as well. But we have, so there's lots of different elements to that course that will be coming online or already online in terms of the management of prostate cancer and you know, recent updates in that regard. But I know that there's also some ones that I haven't been involved in, but there's so many good resources on the Prostate Cancer UK website from a supportive care point of view on sex and prostate cancer, exercise and prostate cancer, just so many great resources. Really do take a look. And I always think it's really important to look at the resources not only for healthcare professionals but also how things are worded to the patients, because I think and people affected, because I think that's a really good way of learning how we can then put things in a clear and concise and enabling way as well.
Thank you so much. As Jo said, it's been amazing. So much covered in quite a short amount of time.
I did have a question for Clive, actually. Is that all right?
Yeah, fire away.
Yeah.
I'll fire one back though.
Yeah, well, I was wondering, Clive, because I touched on it. You know, do you think there is that potential with SABR where we might start finding that, for example, you know, because we're looking at escalating dose to the pelvic lymph nodes with SABR, but also Pivotal's looking at that, isn't it? You know, do you think for some men we are getting a little bit nearer that point where they maybe don't need to have as much hormone therapy? Or do you think, I know that obviously there's a reason for that systemic approach for the, you know, metastatic disease, but I just wondered for, say, locally advanced.
Yeah, no, unfortunately the problem is, you know, the sort of the higher the stage, the more likely you are to have micrometastases, and they're not necessarily just in the pelvic lymph nodes, because obviously people don't just relapse in the lymph nodes, they relapse in bones as well. So those micrometastases, those little buggers, they're all over the place, unfortunately. So you need a systemic approach to knock them out. And the clinical trials in you know, the higher risk disease have shown it at least a 10% absolute survival benefit by adding androgen deprivation therapy. That's for high risk disease, so that includes your locally advanced. So I don't think we completely can get away, because you're so right. I mean, your talk was fantastic. It really highlights that hormone therapy for a lot of men is horrible. I mean, it's a really odd one. Some men have hormone therapy, and I ask them, how are you getting on? They say, fine, carrying on, no problem whatsoever. Others, it can be devastating, like seriously devastating to their lives. And for most people, on average, it at least causes fatigue, but you can get sarcopenia, which is muscle loss, and that's why I loved your talk, because it focused heavily on exercise. And I really want to reiterate the importance of exercise if you've got prostate cancer, you know, especially if you're on hormones, but just in general, exercise is really, really important thing to do. You know, pelvic floor as well. But yeah, get out. You know, just, you know, if you are limited in where you live, and you can still go out for a walk. You know, that's great. You know. The other good one is just sort of standing to sitting. That's a really good, easy to do in your living room, even when you're watching the box. Just do that for 30 seconds to a minute. And that whole thing about prehab you brought up as well. So if you're, before an operation or radiotherapy, that could be really helpful. So I think all those things help. And I think, that I'm afraid hormone therapy is here to stay for men with more advanced disease. It does make a big difference. The good thing is, though, we do seem to think that 24 months is as good as 36 months, because we used to give three years of adjuvant. I now give 2 years of adjuvant. And if people are really struggling, I'll give 18 months or even a year. Some hormones are better than no hormones. So I think that's really important. Another important learning point is if you're a patient who's really struggling with the hormone therapy and you're just desperate to get to the 2-year mark, but you're just having a miserable time at 9 months, that might be enough to make a big difference. Most of those benefit is going to be in the first 6 to 9 months, maybe, where you get most benefit. So you haven't lost out if you have to drop out. So I mean, it's not the end of the world if you think your life is really, really awful to ask your doctor, let's say, I really need to come off treatment. And I've stopped treatment many times before the 2 years is up. So don't be frightened to ask your clinician, that important question. Quality of life is so important. You're going to have a good long-term prognosis, even with locally advanced disease. Most men actually are probably going to have, a normal life expectancy. For a few, clearly it's going to shorten life expectancy. The majority will still, I often say in clinic, you're going to be an old man one day, and that's my sort of catchphrase. And that's the truth for the vast majority of men that we treat. It's, the treatments are really effective.
I think that's with regards to that, I think, especially with like the hormone therapy, but some of the side effects, they can get confused with the aging process, can't they? Because a lot of it is linked, they will inevitably get some of these side effects due to aging anyway, like, a slightly poorer urinary continence, or, a decline in sort of muscle mass and strength. So it's just another reason why the exercises are just so important generally, aren't they? Regardless of whether it's due to the radiotherapy or other treatments or not, it's just good practice that everybody should be doing, and I should probably be doing them more as well. But
we should all be doing it. Yeah, I couldn't agree more. Really, really important. And another key thing is if people have been on the injection forms of treatments, the sort of full androgen deprivation therapy, your sort of Zoladex injections, your Degarelix injections, when you stop them, interestingly, some men never fully recover their testosterone. So it is important to say to them, we're going to stop your hormones, but the effects could last for many months. And unfortunately for some men, they never fully recover their testosterone level, and they may remain castrate for the rest of their lives. And then you get into the really interesting discussions. Well, should you have testosterone replacement therapy? Again, that's another rad chat. There you go.
There's only so much time in our lives.
Yeah, but it's prostate cancer is so interesting, and it's I think the men listening out there as well, who may be having the disease. There's lots of things to be optimistic about. Obviously, unfortunately, it still kills 10,000 men a year, but that's most of those men that present with very advanced disease. The patients with localized and locally advanced disease, they tend to do really, really well. I think Amy was going to come in there, wasn't she?
Yeah, it was a question. We had a lot of questions from the press a couple of months ago when Rylance was approved, which is the first ADT taken as tablet form. And one of the pros of that seems to be that you don't have that long-term impact on testosterone. So when you stop taking the tablet, the testosterone levels go straight back up rather. And I think when we were looking at the announcement, the group of patients for whom it seemed most relevant is those patients who are having ADT alongside radiotherapy, where there is a definite end date in mind for that ADT. And my curiosity was whether you're seeing that used in clinical practice yet, or whether it's still far too soon to see new treatments like that coming into your clinical practice.
Yeah, that's a fantastic question, and actually so relevant because it really is becoming a topic of discussion amongst clinicians, especially sort of clinical oncologists or radiation oncologists like myself, because that's classically the area where you think it might be of most benefit. it is causing some considerable debates, and one of the reasons for that is, when men stop that ADT, obviously it still has a long-term effect, but is that long-term effect one of the benefits? We don't know. Obviously I've told you that 3 years is just as good as 2 years is just as good as 3 years, etc. But is that just because a lot of the effects are so long-standing, and therefore if you take that long-standing effect away, will you lose some of the benefits? I probably think it's probably safe. I probably think it's okay, but it's enough to people getting their scratching their chins and thinking, is this absolutely the right thing to do? So until you've got the trials to prove it, some clinicians won't change their mind and they'll stick with their old ways of doing things. But again, it's one to have a discussion with the patient, isn't it? And just say, look, we're uncertain about this, but when we do stop it, then there's much less risk that you're going to end up with these side effects long term. So, I'm happy to go down that approach if you want to, but I think it has to be a proper discussion, because I don't think we've got enough sort of evidence to feel it's really super safe to do that, and you get the same outcome. So that would be really interesting, how the company sort of puts that. I mean, the other thing is intermittent hormone therapy, when people have got metastatic disease. So it seems attractive for that. But in a way, is intermittent disease now becoming outdated because of the fact that people are rarely just on ADT alone these days? They are on other drugs like enzalutamide, darolutamide, apalutamide, all these abiraterone, all these other drugs, and you need to carry on those alongside the ADT. You don't stop them. So, because I used to love doing intermittent hormone therapy, but actually I think, well, I can't really do it anymore because you're on this. I can't stop both drugs, because the whole point of those drugs is you got your benefit by using them early in the course of the disease, and you should continue them as per protocol, which is long term. So that's another interesting area for Prostate UK to look at is, have we seen the end of the era of intermittent hormones? So yes, absolutely fascinating. That's a great question, and again, you should have another discussion in Prostate UK about that because it's not without its issues.
Brilliant. Well, thank you ever so much, everyone. We appreciate everyone who kept on. I know we've gone a little bit over time. Please do fill out the evaluation form, and I'd just like to thank our 3 amazing guests for all of their time this evening. This will be loaded onto YouTube channel and shared with you all along with your CPD certificate. So thank you all for joining us, and good night. Thank you.
Thanks.